welcome to the BBRAUN sponsored symposium on lesson learned and extended therapies in CRRT. We have the pleasure today to host two very important speakers, Professor Antoine Schneider from the Lausanne University Hospital and Service of Medicine Intensive. And then Professor Vito Marco Ranieri from Alma Mater Studiorum, the University of Bologna, Policlinico Sant'Orsola. In particular, we will deal with the extended applications of CRRT in light of the most recent release of the new machine called Omni from BBRAUN. So with no further ado, I will ask Professor Antoine Schneider to share his screen and start his presentation about citrate anticoagulation in convective and diffusive CRRT. Antoine, the floor is yours.
Thank you very much, and thank you for the invitation. So, can't change my slide, sorry. Yeah, sorry. So as you all know, citrate anticoagulation is becoming the standard for anticoagulation for CRRT. This has been recommended by the KDIGO Society by now more than almost 10 years. Citrate is associated with less complication, longer filter life, less downtime, lower cost. This is data from my center. I will go really quickly to just show you that in real life, we have a much longer filter life, almost 3 to 4 times longer filter life when you perform citrate versus heparin anticoagulation. Then, of course, there can be complications going with citrate, and that's why some of you are still possibly reluctant to use it as a therapy, as a default therapy, sorry. And those situations where it can go wrong are the patient with shock, issue with their mitochondrion or liver failure. In this situation, I would not consider as contraindications, but rather situation at risk of accumulation. Indeed, in this situation, either the delivery of the citrate to the organ because of circulatory shock, the organ function themselves, the mitochondria, blocks the citric acid and therefore the metabolization of the citrate, which can therefore accumulate. And then when it accumulates, it will not go through its regular metabolization. It will not generate alkalotic load and increase the or not buffer the metabolic alkaloacidosis related to acute kidney injury. And on the other hand, the calcium that is bound to the citrate will not be released, leading to hypocalcemia. Both these abnormalities might lead to severe issues for the patient. So under normal situation, there is limitations of how much citrate we can metabolize. But in these situations of shock or severe liver failure, again, this threshold is simply moved to the left. Therefore, at a lower citrate rate, the patient is likely to accumulate citrate. So for all patients, we need to follow very strict protocol to monitor arterial blood gases and mostly the pH and the total over ionized calcium ratio, which is an indicator of accumulation. You have to select patient if you have low experience with citrate, the patients which have low risk of accumulation. And for all of these, you want to minimize the citrate load that is administered. And to do that, because the citrate administration is coupled to the blood flow, you will want to use the lowest blood flow as possible and the highest effluent flow, which then will remove the majority or at least the maximum possible amount of citrate. So, that said, we have different modalities for CRRT that are available. As you all know, the CVVH, continuous venovenous hemofiltration, CVVHD, continuous venovenous hemodialysis, or continuous venovenous hemodiafiltration. All these modalities are available on all current generation CRRT devices. All current generation filters can be used to perform these 3 therapies. And there is no clinical data that has demonstrated superiority of any of these modalities in terms of patient-centered outcome. So you can ask, which one should I use for my patient? And I think there is uh, no good or wrong answer in general, but when you want to use citrate, I think there is one, and I will try to convince you why I think CVVHD or diffusive diffusive associated therapy should be utilized. And the first one is linked to what I was explaining to you before, is the need or the not the possibility to run the therapy with low blood flows. Indeed, in CVVH mode, we have the filtration fraction issue. Obviously, we're doing hemofiltration, so we dilute the blood, and then we do filtration. So we remove some volume, some plasmatic volume from the blood, and therefore we concentrate the plasma, leading to concentration of the coagulation factors of the platelets and increasing the probability of clotting. So the more you do filtration, the more likely the filter and the circuit is likely to coagulate. So you want to, at all time, try to minimize this filtration fraction in order to minimize the risk of coagulation. In CVVHD mode, because you don't do filtration, you don't have this concentration, and this is not a problem. So the only way to maintain a high filtration fraction at a given renal replacement therapy dose is to increase the blood flow. In CVVHD, sorry, you don't have to do this thing. So you're not limited by this factor. And this will not decrease the efficacy of your dialysis, because unless you go extremely down, very low with the blood flow, as illustrated in this by this publication here, you see that only if you go really, really low, perhaps under 30 mils per minute of blood flow, then you will have a decrease. But for any value that is reasonably possibly used in clinical practice, such as 60 or 80 mils per minute, you will not have, the blood flow will not be the limiting factor. So essentially, blood flow does not influence clearance as long as it's not too low, and you don't need to have high blood flow. So in CVVHD mode, you can perfectly run the therapy with low blood flow. Why does that matter? First, because low blood flow makes the therapy easier to run. So there's less strain on the catheter, less interruption. And that's been demonstrated by this nice recent paper published in Blood Purification, where you can see that therapy in CVHD mode with no anticoagulation, irrespective of the coagulation, the circuit will lasting longer compared to CVVH. So probably related to a lower strain on the catheter and other aspect. The other thing is low blood flow, again, means less citrate administered to your patients, so less risk of complications related to the therapy. And then you might be able to administer citrate or use citrate for patients for which you would feel uncomfortable using it, for marginal citrate patients. CVVHD, because again, you're not linked to this filtration fraction issue and coagulation, you don't have to actually use pre-dilution. Pre-dilution is an invention of wasting the dose of renal replacement therapy that we give before the filter only for the sake of maintaining filter patency. Obviously, the more pre-dilution, the lower, the more dose you waste, and therefore the lower the efficacy of your therapy. In CVVHD mode, you don't need to use this pre-dilution because there's no filtration once more. And then the argument of clearance, CVVHD has been unpopular because we're worried that the clearance might not be efficient. I think this argument is not valid, at least for small molecules. As you can see here, urea, creatinine, the clearance is perfectly similar. And those are the molecules we're very most interested into clearing. Obviously, for a bigger molecules such as beta-2 microglobulin, the clearance is indeed with a regular filter lower. However, now there's some new generation filters, or maybe not so new, but the high cutoff filters, and it's been shown that these high cutoff filters are able to compensate, and the difference is not as striking anymore, with even perhaps in a higher clear in this study for the therapy run with the CVVH with high flux membranes. The last reason I would say is that CVVHD is associated with less clogging. Indeed, when you have hemofiltration, there is, so through this this process of going through the membrane through the pressure, there is a deposit of proteins on the layer of the membrane. This is termed clogging, and this decrease the diffusing and the ability of the membrane to do his work and to clear the blood from the unwanted molecules. And this has been demonstrated here with the decrease in the clearance over time during the therapy in CVVH mode. It's much less impressive in CVVHD mode. As you see here, the clearance remain much more stable throughout the duration of the therapy. So altogether, CVVHD, when you want to use citrate anticoagulation, should probably be favored because it is associated with a longer circuit lifespan. It might also contribute to the effect of citrate itself. It makes citrate usable for more patients because you use, again, less blood flow, so you administer less citrate. It has a similar clearance with less clogging issues, and therefore the clearance remains stable or more stable over time, and therefore you are less worried about a decrease in clearance over time. Then if you really want to do some form of filtration, you are still able to combine the two. And some companies are actually using as a default CVVHDF as a modality. I think it's an in-between combination, and this is perfectly fine to use. It's been used with with some other devices very commonly. The Omni is also able to run the therapy in citrate mode in with citrate in CVVHDF mode. It's not currently fully available. We are testing it at the moment in our center. We've already made some adjustment for the therapy, and it's working. So it will soon be released as a general protocol. We're testing it, and we will present the data hopefully very soon, perhaps in blood purification. So this brings me to my conclusions. I think that CRT in CVVHD mode facilitates regional citrate anticoagulation because it requires low blood flows, it removes the need for pre-dilution, and it provides excellent clearance for low to middle molecules, or at least very good for middle molecules. And then the alternative is CVVH, which is currently under evaluation and will soon be available with the Omni. Thank you very much.
So, Antoine, thank you very much. While you stop sharing your screen, and Professor Ranieri will begin sharing his own screen, I must say that some years ago we did a consensus conference with Jean-Louis Vincent in Belgium, where we were analyzing the possibility to perform echoes, defined as extracorporeal organ support, and especially somehow combining different type of organ support, including patient with respiratory failure and patient with acute kidney injury. The claim was to try to get a combination of the therapies and possibly to have also a type of hardware that was actually offering the possibility to act as a platform for all these different therapies. And today, Professor Ranieri will speak with us about his experience of acute renal failure and acute respiratory failure. Curiously enough, both could be abbreviated in ARF, possibly actuating the combination of therapies to support both organs, the lung and the kidney. Marco, please.
Thank you very much. And let me start with some pathophysiological background for this idea. And of course, I have to quote our chairman in this context that, as alluded before, elegantly described in this review article published in the Blue Journal a number of years ago, the possible mechanisms that are involved in the so-called crosstalk interaction between the lung and the kidney, where in this case is the lung, the motor, the lung injury that is the motor of a crosstalk into direction of the kidney. So what is going on into the lung is somehow affecting the kidney. And on the other hand, in this case, is the kidney, is the pathological process involving the kidney that is somehow involving the lung. So there is a valid biological, pathophysiological background to support the concept of co- uh, consistent treatment for both injuries. There are also some interesting data that actually are almost 20 years old, actually 20 years old. This is a paper that we published in 2000, where we describe the incidence of multiple organ failure in the context of prevention of ventilator-induced lung injury. We have patients ventilated with high tidal volume, low PEEP, so patients exposed to ventilator-induced lung injury, randomized versus patients treated with low tidal volume, high PEEP, therefore preventing ventilator-induced lung injury. And overall, we were able to see that low tidal volume was associated to less clinical expression of multiple organ failure. But when we blow up the data, we could see that actually the organ that were more sensitive to low tidal volume in terms of organ protection was the kidney. So supporting the concept that years later was so elegantly described by our chairman. And later on, putting together experimental and clinical data, we were also able to provide a sort of physiological rationale for this. Now you see in black, patients ventilated with high tidal volume. In gray, you see patients ventilated with low tidal volume. On the horizontal axis, you see the change in plasma concentration of Fas ligand. That is one of the most relevant mediator for apoptosis. That is the biological mechanism by which cells die in the context of organ failure. And on the vertical axis, you have changes in plasma creatinine concentration. And you see that with high tidal volume, you had an increase in plasma concentration of creatinine, and this increase in concentration was related to an increase in plasma concentration of Fas ligand, suggesting that the use of high tidal volume is associated to organ failure, in this case, to kidney failure, because of an increase of the pro-apoptotic pathway associated to the high inflammatory response that has been described in ventilator-induced lung injury. So we have nowadays technology that combines the possibility to have lung support, extracorporeal lung support, having an oxygenator in series with an hemofilter that provides kidney support. So it's possible to provide an extracorporeal circuit that is able to provide lung support and kidney support. There are a number of studies that tested the feasibility of this approach. This is one of the first, published on Critical Care in 2013. They use a homemade created system. And by using this homemade created system, it was possible to see that using at the blood flow in the range of 200 to maximum 400 ml was possible to support with an ultrafiltration rate in the therapeutic range to provide renal support, allowing the use of very low tidal volume. And here you see the effect in terms of oxygenation, PCO2 and pH of the use of this low tidal volume supported by the use of the extracorporeal circuit that remove the excessive extracorporeal CO2 produced by the low tidal volume, consistently with the support of the kidney function. Later on, these data were confirmed in this study published on Critical Care Medicine that again supported the idea that combining renal replacement therapy with CO2 removal was safe, allowed a super protective ventilatory strategy consistently with the target of supporting the kidney function, and the way how the system was designed in terms of putting the hemofilter before or after the oxygenator had an impact on the safety and the efficacy of this treatment. But are there data showing a positive clinical signal of the combined therapy, extracorporeal therapy? This is, as far as I know, the only study available that we performed a number of years ago in 4 Italian ICUs, where we treated patients with acute respiratory distress syndrome and renal failure with a device that was able to provide at the same time renal replacement therapy and partial extracorporeal support. So this is the intervention group, and the control group was renal replacement therapy alone with mechanical ventilation provided according to the conventional protective settings that were selected with matching statistical technique. The study outcomes was the pro-inflammatory signal in the plasma, measuring a number of pro-inflammatory mediators, but essentially IL-6, the pro-apoptotic signal available in the plasma with the 2 intervention, and the clinical outcome was the reduction in creatinine concentration, days on renal replacement therapy, and eventually ICU and hospital mortality. Here you have the data of the 2 groups of patients. And as you can see that in terms of a number of variables, age, SAPS, injury, kidney injury, days on mechanical ventilation, and so on, the matching procedure was able to create 2 compatible groups in a way simulating what we would see in a randomized controlled trial. And here you have some of the results. In terms of pro-inflammatory signal, combination of super protective strategies, so a very low tidal volume dealing with the excessive CO2 with the oxygenator, and renal replacement therapy was able to attenuate the pro-inflammatory signal as compared to conventional treatment, where renal replacement therapy was associated to conventional mechanical ventilation. And the attenuation of the pro-inflammatory signal was consistent with an attenuation of the pro-apoptotic signal that in the plasma. But importantly enough, we were also able to see a clinical signal in this experiment. First of all, we saw a significant reduction in days on dialysis, and we see a more enhanced reduction in creatinine when renal replacement therapy was associated to partial extracorporeal support. We were not able to see a significant signal in terms of outcome, but I mean, we would not be surprised of this result given the relatively small sample size. Now, this is the COVID area, and we have to say something about the potential use of this technique in the context of the treatment of patients with COVID-19 induced ARDS. And here we have centers that are accumulating data on this technique. But I want to end my presentation with the case report. Now, this is a patient that was reported to us in the emergency department very early on the first wave, and the patient was treated with CPAP because of a severe involvement of the lung function, as can be seen with this CT scan. Now, immediately after, the patient worsened the respiratory condition, was admitted into the intensive care unit, intubated, use of prone positioning, muscular relaxant, and again, because of the substantial worsening of PF ratio. At a certain time, he developed pneumonia, and the worsening of the respiratory function was evident, and with a PF ratio of about 53. At that moment, he developed acute renal failure associated to septic shock, and we were not able to provide protective ventilatory settings. With a tidal volume of 6, plateau pressure was higher than the target of 30 centimeters of water. So we had a problem on the ventilation side that was consistent with the problem on the kidney side. So we decided to provide extracorporeal support to treat acute renal failure and to allow protective ventilatory strategy. And by doing so, we were able to regain control of protective ventilatory strategy by reducing driving pressure, by reducing respiratory rate, by regaining control of PCO2, and by keeping control of norepinephrine infusion. And by doing so, we were able to wean the patient off the ventilator on pressure support and then eventually dismiss the patient from the ICU. Now, what did we learn? We decided to intervene when we lost the control of the possibility to perform protective ventilatory strategy. And so we therefore intervene here. Probably the intervention had to be taken place much early on. And instead of waiting for the clear manifestation of ventilator-induced lung injury, we may think about to prevent the use of this combined support much early on. Of course, only results from randomized controlled trial may say the final words. I'm happy to say that if COVID-19 will allow us to get back to standard clinical work, we will able to start this randomized controlled trial where we want to use strictly criteria to randomize patients with moderate to severe ARDS to renal replacement therapy only and renal replacement therapy plus partial extracorporeal support, having as a primary endpoint days free from renal replacement therapy and with a sample size of close to 100 patients. Let me conclude with this picture because it's a very tough moment, and I want to say that we will make it, we will go through. Thank you very much.
So thank you very much, Marco. We don't have too much time. We have approximately 2 minutes left. So I would go immediately to Antoine Schneider asking the typical question. Are you feeling that the dose that you can deliver to your patients is definitely improved since you used the citrate anticoagulation?
Yes, I mean, the total dose over a day for sure, because there's, I mean, I've shown the data published in Blood Purification from our center. It was retrospective, and it's the filter life is 4 times longer. Because we don't have interruptions during the therapy, the dose, I mean, at least the estimated dose is improved. At least the time during which the therapy is administered during the day is improved. So then if you then assume that the clearance is stable or almost stable over time, then you must increase the dose delivered to the patient. Yes, so we don't measure as a routine the clearance and the ratio of urea on the filtrate over the blood to be able to 100% respond to your question, but you would assume that with a longer filter life and a supposedly stable clearance, you would have a higher delivered dose to the patient.
Very good. Marco, do you plan a special vascular access at the beginning now of your patients in the ICU, supposing that you will treat them with ECHO plus CRRT?
Now, ideally, it should be a double lumen 14 French catheter, ideally inserted through the neck, because the ventilatory management may be problematic in terms of kicking coagulation. Now, it's not exactly a piece of cake to put the 14 French through the neck, but that's the ideal. I mean, if this is special, that will be special.
And what is the blood flow that you recommend in this combination therapy?
300, maximum 400 ml per minute.
So I'm very glad to see that my dream to have high dose delivered by anticoagulation that allows to keep patency of the circuit, and to have a MOST machine that provide multiple organ support therapy is now materializing. I thank you both for your presentation, BBRAUN for the sponsoring this symposium. And I wish we can further deepen our knowledge of this topic in the future that apparently is so important for our patients. Thank you so much.
Thank you very much. Bye-bye.
Thank you. Bye-bye.
Bye.